term lenticonus has been used to describe a protuberance of the anterior or posterior surface of the lens. Anterior lenticonus is a transparent, localized, sharply demarcated conical projection of the lens capsule and cortex which is axial in location. A corresponding oil droplet reflex can be seen on distant direct retinoscopy. Sometimes it can be seen in association with various systemic conditions like Alport syndrome, spina bifida, and Waardenburg syndrome. Alport syndrome is classically described as a triad of renal manifestations, sensory neural deafness, and ocular manifestations like anterior lenticonus, flecked retinopathy, and posterior polymorphous dystrophy. Progressive increase in lenticular opacity following spontaneous rupture of the anterior lens capsule and high irregular astigmatism in a case of lenticonus both require immediate surgical intervention for better vision restoration in these patients. Clear lens aspiration for anterior lenticonus has been described in the literature. The anterior capsule in lenticonus is extremely fragile and elastic and needs to be handled meticulously. High molecular weight viscoelastics have been advocated to keep the anterior capsule flat during capsular excess. Using an adequate amount of hydroxyl propyl methylcellulose or HPMC2 would suffice. As the central part of the capsule is extremely fragile and difficult to handle, starting the capsular rhexis in the mid-periphery has been advocated. The needle must be sharp to avoid any irregular or star-shaped tear, as that would possess a high propensity to extend to the periphery. The tear is then guided using pediatric rhexis forceps. As in any pediatric cataract surgery, it is of utmost importance to direct the tear centrally, as otherwise it tends to direct itself more peripherally. Maintaining an adequate bottle height and the least fluctuation in intraocular pressure during maneuvers is important. Increasing the magnification, light intensity, dimming the operating room lights and taking the help of the background fundal glow, and instilling an adequate amount of viscoelastic helps in better visualization during rhexis. Sometimes the anterior capsule is so thin that it leads to spontaneous rupture and subsequent cataract formation. In this situation, an initial nick can be given on the anterior capsule with a microscissors, and later the anterior rhexis can be fashioned with a pediatric rhexis forceps. Gentle maneuvering is required to be done as the posterior capsule can be thin or may have a posterior lenticonus and can lead to a spontaneous rupture during cortical matter aspiration. In the bag intraocular lens implantation is recommended whenever possible. Posterior lenticonus is characterized by a posterior ectasia of the posterior capsule. This can result in myopia, irregular astigmatism, and a progressive cataract. Sometimes it can be associated with pre-existing defect in posterior capsule, which is characteristically elliptical in shape. The defect in the posterior capsule can cause migration of the lens matter into the vitreous, giving rise to the fishtail sign. Modern microsurgical techniques have minimized the rate of complications in a case of posterior lenticonus. Hydrodissection should always be avoided in posterior lenticonus. During cortical aspiration, the irrigation and aspiration parameters should be low. The peripheral cortex is always aspirated first, leaving the nucleus to support the lax posterior capsule. Then, the nucleus and the posterior cortex are removed, taking care to preserve the posterior capsule. At times, the posterior capsule is so fragile and thin that it first requires an intraocular lens implantation in the bag, followed by a primary posterior capsular rhexis using an automated vitrector. In case of total cataracts, it is difficult for the surgeon to gauge the integrity of the posterior capsule and the amount of posterior capsular defect, if any. In the event of posterior capsular rupture during cortex removal, or a pre-existing defect in the posterior capsule, as in this case, automated vitrectomy is performed and whenever possible, an attempt should be made to implant an acrylic hydrophobic intraocular lens in the bag. Lens styling should be avoided. Instead, the trailing haptic can be gently nudged inside the bag. In patients with insufficient capsular support, a 3-piece acrylic-type intraocular lens can be implanted in the sulcus. Before concluding the surgery, one should ensure the absence of vitreous strands because cataract surgery in posterior lenticonus can be associated with high positive pressure from the vitreous, and there are chances of vitreous loss. We have watched a few modifications in the technique of cataract removal surgery when it is associated with anterior lenticonus or posterior lenticonus. The modified techniques described in this video will help surgeons tackle more confidently the double trouble of cataract in anterior and posterior lenticonus and benefit the patient by giving them a better surgical outcome.